All right, in this one, we are going to cover 6 different Heme Onc cases. They're going to be relatively quick cases that we can work through. I've then got like follow-up questions that'll kind of integrate a lot of things together. Obviously, I can't cover everything, but I just picked 6 different cases that I had seen over and over again on MBMEs and that I've seen now for the past year and a half. I've been on rotations that have come up multiple times, so it's important things to think about. Um, so let's start with case number 1. We have a 65-year-old man presents to your clinic complaining of progressive fatigue, numbness in his feet, and difficulty walking for the past 2 months. He states that he often feels off balance, especially in the dark. He also reports occasional tongue soreness and a burning sensation in his hands. His past medical history is notable for type 2 diabetes and hypothyroidism, both that are well controlled. He does not follow a vegan diet and denies alcohol or tobacco use. Vital signs are stable. On exam, you note pallor, a smooth red tongue, and impaired vibration and position sense in the lower extremities. Reflexes are brisk. His Romberg test is positive, and there is no hepatosplenomegaly. The rectal exam is negative for occult blood. We get some labs on him. We see his hemoglobin's 9.1, his MCV is 115, reticulocyte count is low, his white blood cell count is 4.1, platelets are 120,000, his smear is shown. Um, so my questions for you guys, and you'll pause the screen and you'll think about them. What is your differential diagnosis for this patient's anemia, giving his clinical presentation and his lab findings? So come up with a good differential. What further laboratory tests would you order to confirm the most likely diagnosis? What's the pathophysiological mechanism behind the patient's neurological symptoms? And then if this patient's not following a vegan diet, how might else you explain the development of this condition? So we've got older gentleman. He's got a type of anemia, right? I'll let you figure out which type of anemia this is. It looks like he has a history of type 2 diabetes and hypothyroidism. He's got some numbness, tingling in his fingers and toes. He's got soreness in his mouth. He's got a smooth red tongue, right? So you guys can kind of do the rest based on labs in the smear. There are my questions. Pause your screen. Think about it. So this is your classic B12 deficiency, right? So when I look at this, right, we have an older gentleman. They've got the fatigue, numbness in the feet, and difficulty walking, numbness in the hands, right? So that's my peripheral neuropathy. He feels off balance. He's got the smooth red tongue. So that's a macroglossia that can develop with B12 deficiency. We see B12 deficiency is classically a megaloblastic macrocytic anemia. So we have low hemoglobin. We have an elevated MCV. We see the reticulocyte count is low. The white blood cells and platelets are also low, so this patient actually has pancytopenia, which can occur with advanced B12 deficiency. So remember, B12 is really important for DNA synthesis, right? We need B12 to make tetrahydrofolate. If we don't have tetrahydrofolate, it's really hard for us to make DNA. And over time, right, that impaired DNA synthesis can lead to full-on pancytopenia. So low red blood cells, white blood cells, and platelets. The low reticulocyte count tells me the bone marrow is not able to respond. It tells me this is more of a bone marrow problem, right? Which this is, because there's a problem with DNA synthesis in the hematopoietic stem cells. And then on my smear, I see some massive red blood cells, right? These are macrocytes. And then I see my hypersegmented neutrophil here. All characteristic of megaloblastic macrocytic anemia. So really, my differential for megaloblastic macrocytic anemia, I should be thinking about B12 deficiency, folate deficiency, copper deficiency, and then bone marrow failure, right? So B12 deficiency, right, this lines up. Folate deficiency can cause a macrocytic anemia, right? But usually not neuroscience, right? Copper deficiency can mimic B12 deficiency in the subacute combined degeneration, some of these neuroscience. It can cause a megaloblastic macrocytic anemia, but it's overall very rare, right? You're going to want to think about copper deficiency when a patient is taking excess zinc, okay? Zinc binds copper in the gut and then you poop it out. So look for a patient who's taking a lot of over-the-counter cold and flu medicines because those have a lot of zinc in them, right? So that can be one key. A patient that uses like a lot of copper cookware is another cause, or just a patient with a really poor diet overall where they wouldn't be getting much copper. Copper deficiency can cause pancytopenia too, so it needs to be on your differential, right? But it's overall rare. And then there are some non-megaloblastic causes like myelodysplastic syndrome that we should consider because this is an older gentleman with pancytopenia. But the fact that this guy has megaloblastic anemia is less consistent with myelodysplastic syndrome. And the fact that this guy has concomitant neurological symptoms is less consistent with myelodysplastic syndrome. Myelodysplastic syndrome, we have dysplasia of my hematopoietic stem cells. So there's irregular movement through the hematopoietic stem cells to make my red blood cells, white blood cells, and platelets. So there's ineffective erythropoiesis. It's not a problem with DNA synthesis, so we don't see that mismatch between the nucleus and cytoplasm in my cells that we see here in these hypersegmented neutrophils. So it's not a megaloblastic problem, it's a non-megaloblastic macrocytic anemia where there's a problem in the cell membrane and the erythropoiesis itself. But myelodysplastic syndrome needs to be on your differential for any older individual who has acytopenia and especially pancytopenia, right? But there are a few things in this case that point me away from myelodysplastic syndrome and more towards B12 deficiency. We also can consider hypothyroidism, right? Because hypothyroidism can cause both normocytic and macrocytic anemia. However, this patient's hypothyroid seems to be well controlled, and really it leads to like a mild macrocytosis. We see this guy has an MCV of 115 and the neurological symptoms more consistent with B12 deficiency. So how do we confirm it, right? We're going to get serum B12 levels, which might be low, okay? Then we'll get MMA and homocysteine, right? So new guidelines state if we're working up B12 deficiency, we should get MMA and homocysteine. Homocysteine is going to be elevated in both B12 and folate deficiency because both B12 and folate are used as cofactors or coenzymes in steps to convert homocysteine into a different molecule. So if we have low B12 or low folate, that homocysteine is not able to be converted and it'll be elevated. Remember that an elevated homocysteine can cause endothelial cell damage, and usually when the homocysteine level is above 30, that's when we can start thinking about clinically significant endothelial cell damage, and we can think about it contributing to a hypercoagulable state. But homocysteine is going to be elevated in both B12 and folate deficiency, so it's nonspecific. That's why we get MMA as well, right? MMA is going to be only elevated in B12 deficiency. B12 is a cofactor for methylmalonyl-CoA mutase that turns MMA, methylmalonic acid, into succinyl-CoA. So if we don't have that B12, MMA rises, okay? So that's only going to be elevated in B12 deficiency. Now, the reason I need you guys to order the MMA and homocysteine is because sometimes patients can have a totally normal level of B12 B12 level, but they're actually functionally deficient, right? So their B12 looks normal, right? The level is normal, but your body isn't utilizing it as well. So in those patients, the B12 level will be normal, but their homocysteine and MMA will be elevated because just because the enzyme has normal or the B12 has normal levels, the enzymes aren't going to be able to function to convert homocysteine into its molecule and convert MMA into succinyl-CoA. So those levels are going to start rising of those metabolites, okay? So don't get fooled by a normal B12 level. Always order the MMA and homocysteine too to confirm if this is a functional deficit. We can also order folate level, right, to rule out concomitant folate deficiency because sometimes they run together. And then we want to consider ordering an anti-intrinsic factor and anti-parietal cell antibodies if we're considering pernicious anemia, right? So sometimes like B12 deficiency is often caused by a long-term vegan diet. PPIs can cause B12 deficiency. We have certain bugs that can cause it. Things like tropical sprue and the D. latum tapeworm, right? Those I would consider in patients who have been traveling overseas. So if we have feasibly ruled out, some of those big name causes, then we can start thinking about things like pernicious anemia, where we have autoantibodies against intrinsic factor, which is really important for transporting B12 to the terminal ileum so it can get absorbed, and then the parietal cell antibodies, which secrete the parietal cells, right, which secrete the intrinsic factor. So if we have antibodies against intrinsic factor or against the parietal cells, we're going to have a hard time absorbing B12. Other things you can consider with B12 deficiency is any kind of damage to the terminal ileum, right? Or any kind of damage to the small intestine or the stomach itself, really, that would cause malabsorption of B12, right? B12 is primarily absorbed in the terminal ileum. So we often think about things like Crohn's disease that loves to impact the terminal ileum. Celiac disease loves to impact the terminal ileum. But really, anything along the whole chain can potentially exacerbate B12 deficiency. Any patient with any kind of like surgery to the small intestine or to the stomach can potentially exacerbate this as well. So if we can feasibly rule out that stuff, and if my patient is a little bit on the older side, those all favor a diagnosis of pernicious anemia, and I'd be interested in getting these antibodies. I actually saw this for the first time in the hospital. Right, I had a patient who had a B12 level that was undetectable. MMA was sky high. I feasibly went through that whole workup and I said, hey, he's not meeting any of these criteria that I think could potentially explain this. I want to order an anti-intrinsic factor and antiparietal antibodies. And they ended up, those tests come back, they take a few days. They ended up coming back positive. And so then we ended up treating the guy long-term with vitamin B12, right? So the neuropathophysiology, B12 deficiency can lead to what's called subacute combined degeneration. Subacute combined degeneration, SCD, impacts the SCD spinal cord pathways. So the S is a spinal cerebellar. So that's going to be like gait ataxia, dysmetria, dysdodiokinesia. The C in the SCD, right, you can think about it as the cortical spinal tract. So weakness. And the D is the dorsal column medial lemniscus. So loss of vibration and proprioception. So overall, we're impacting the spinal cerebellar, dorsal column medial lemniscus, and cortical spinal tract. When we have low B12, it impairs the myelin synthesis and it leads to an elevated levels of MMA. MMA is neurotoxic and we have low myelin, so we're having a hard time shuttling my neurotransmitters throughout my nervous system. And then we lose that loss of vibration and proprioception and get spasticity. And then, so again, some non-dietary causes. We've talked about a lot of these. Pernicious anemia, autoimmune intrinsic factor loss, post-gastrectomy bypass, ileal disease, certain bugs like D. latin and tropical sprue, chronic gastritis, maybe secondary to H. pylori, where we don't have the proper pH levels in the gut to cause the release of intrinsic factor. And then nitric oxide itself can inactivate B12. Okay, so think about a patient using whippets. It's usually like a teenager who is like snorting the whippets, the cans of nitric oxide. Okay, so remember B12 is found primarily in animal products. Folate is primarily found in foliage or cruciferous vegetables. B12 deficiency takes many, many months to years to develop. Folate deficiency really only takes a very short period of time. Folate deficiency is really hard to get nowadays because a lot of our food is fortified with folate. But you can think about it in a patient who has maybe alcohol use, right? Because alcohol inhibits or it messes with folate metabolism. Maybe a patient taking Bactrim, right? Because the TMP blocks dihydrofolate reductase. The SMX blocks dihydropaterate synthase. So it blocks that pathway. Methotrexate, right? Which is a commonly used DMARD in a lot of diseases that blocks dihydrofolate reductase. And then pregnancy itself, right? Pregnancy over where like it's a hypermetabolic state. We're using a lot of our cells. We're using up that folate. That's why we prescribe folic acid to pregnant women. And then you can think about like diseases like sickle cell disease, hereditary spherocytosis, where we get rapid turnover of our cells, our red blood cells, and we're using up the folate pretty fast. All right. So that was kind of B12 folate deficiency, thinking about macrocytic anemia as a whole. All right. Other causes, I'll just point out, just because we talked about it, other causes of non-megaloblastic macrocytic anemia, other than myelodysplastic and hypothyroidism, you should think about liver disease, alcohol disease, or like alcohol use, and reticulocytosis are other major ones, right, that are going to cause abnormal damage or abnormal findings of the cell membrane that leads to a larger macrocytic red blood cell in the absence of causing problems with DNA synthesis. All right, so case number 2. In this one, we have a 15-year-old boy presents for the evaluation of fatigue and intermittent jaundice. His parents report that he has looked yellow after viral illnesses since childhood. He has had no prior surgeries. Family history is notable for his mother having a blood disorder requiring her spleen to be removed in her 20s. He denies recent travel, sick contacts, or new medications. On exam, you note mild scleral icterus, splenomegaly, and pale conjunctiva. He has no lymphadenopathy or hepatomegaly. His labs are notable for a hemoglobin of 10.2, MCV of 82, MCHC of 38, which is elevated, a reticulocyte count that's elevated. He has elevated LDH, low haptoglobin, elevated indirect bilirubin. I showed you his peripheral smear, and we got a direct Coombs test that was negative. So what I want you to think about is, why is the MCHC elevated in this patient's condition? What else should be on your differential diagnosis when we see spherocytes on the peripheral smear? What is the gold standard test to confirm the diagnosis most likely in this patient? Why are patients with this condition at increased risk for gallstones? And when should you consider performing a splenectomy in these patients? So pause your screen and think about everything. So this one is classic hereditary spherocytosis. So what kind of keys me in, right off the bat, on my peripheral smear, I see spherocytes. Just because I see spherocytes does not mean it's hereditary spherocytosis, but obviously it's part of the disease, so it leans me towards it. I see a relatively younger individual who has a family history of some sort of blood disorder that required a splenectomy, also leaning me towards more of a hereditary pattern. Um, we see this kid has been jaundiced after viral illness, right? So that tells me maybe he's got elevated indirect bilirubin at times of increased stress. And then what kind of seals the deal is we have anemia, right? A normocytic anemia, which is classic of hereditary spherocytosis. I see elevated reticulocyte count, which tells me it's a peripheral destruction. Because remember, my differential for normocytic anemia, I can think about hyperproliferative versus hypoproliferative. And in hyperproliferative, where the bone marrow is able to respond appropriately, we think about hemorrhage, hemolysis, and hypersplenism, right? So hereditary spherocytosis is an example of hemolysis. We have my classic hemolytic labs, right? Elevated LDH, low haptoglobin, elevated indirect bilirubin. I've talked about this in several videos now, but when the red blood cells get sheared or they get hemolyzed, they release LDH, they release free heme, they release indirect bilirubin. The free heme gets bound up by haptoglobin, so the haptoglobin levels end up being low. We did a direct Coombs test, which you should always do when you suspect hemolytic anemia. The direct Coombs test will test for autoantibodies that are causing the destruction and the hemolization of these red blood cells, right? So that would be in things like autoimmune hemolytic anemia, maybe secondary to warm and cold agglutination disease, right? So warm agglutination, classically like lupus, CLL, other kinds of autoimmune diseases, right? Other kinds of cancers. Cold agglutination, classically mycoplasma, EBV, right? So the warm agglutination is IgG, cold agglutination is IgM. We have autoantibodies that attack and then trigger for intravascular and extravascular hemolysis, right? Via complement or via macrophages. But because the direct Coombs test was negative, it tells me it's not an autoimmune process, right? So this is not an autoimmune hemolytic anemia. And what classically sends us home is the MCHC is elevated, right? The MCHC we'll talk about in a second, but that's also a classic finding in hereditary spherocytosis. So why is the MCHC elevated? The MCHC is mean corpuscular hemoglobin concentration. So if you think about your red blood cell, right? A normal red blood cell, the hemoglobin makes up X amount of the red blood cell. Let's just say, for sake of to make it easy, the hemoglobin makes up 50% of the red blood cell. So what happens in hereditary spherocytosis, there's an underlying defect in some of my cytoskeleton proteins. So those are things like band3, ankyrin, and spectrin. When those red blood cells make their way to the splenic macrophages recognize the abnormality in the cytoskeleton, and they're like, yo, this is way off. And it eats up the outside of the red blood cell to remove those abnormal proteins. And so what happens is we remove some of the outside area of the red blood cell without touching the hemoglobin. So now the hemoglobin hasn't changed, but the total area of the red blood cell is smaller. So now instead of the hemoglobin taking up 50% of the red blood cell, because we remove some of the outer edges of the red blood cell, that hemoglobin is saying, let's say, takes up 75% of this new red blood cell, this spherocyte. So the mean corpuscular hemoglobin concentration has gone up. That's the way you can think about it. Now, the MCHC will be elevated in any kind of cause of spherocytosis, right? Which kind of leads into my next cause or my next question. When I see spherocytes, we should really be thinking about two massive kind of things. Autoimmune hemolytic anemia, which we just talked about, would be Coombs positive, and hereditary spherocytosis, Coombs negative. Less specific and less common, burns and sepsis. But really, for step one, step two, I want you thinking about autoimmune hemolytic anemia in hereditary spherocytosis. So the MCHC is usually elevated in both of those. The gold standard test to diagnose hereditary spherocytosis is this EMA binding test. We use flow cytometry. It detects decreased membrane protein expression of ankyrin and spectrum. You might see in older textbooks the osmotic fragility test, and maybe that still shows up in practice questions. That's no longer the gold standard. This EMA binding test is now the gold standard via flow cytometry. Why do these patients have an increased risk of gallstones? Well, the chronic hemolysis increases the amount of free indirect bilirubin, or the unconjugated bilirubin, which will precipitate in the bile and can cause these pigmented black stones or these pigmented gallstones. So look for a patient in hereditary spherocytosis that also has a history of cholestasis or biliary colic or cholecystitis or choledocholithiasis or cholangitis, right? So they'll often kind of try to be tricky with you and give you a patient who has a history of their gallbladder being removed, or they'll give you a history of hereditary spherocytosis, and somehow all the answer options are relating to the gallbladder. That's because they can lead to gallstones, and potentially end up removing the gallbladder due to symptoms, right? Um, and then when do we consider splenectomy? So in moderate to severe anemia, growth delay, or recurrent hemolysis despite folate support, we might consider it. The splenectomy will improve the anemia by removing the site of red blood cell destruction, right? So if I remove the spleen, I'm removing those macrophages that were leading to the destruction of these red blood cells, or to the eating up of the outside of the red blood cells. So if we remove the spleen, we remove the macrophages, and that leads to my red blood cells circulating without having this chronic hemolysis. We usually delay the splenectomy until after age 5 because it lowers the infection risk, but we'll have to vaccinate against encapsulated bacteria, and I have a question on this in a later case. So that's kind of the gist on hereditary spherocytosis. Very, very, very high yield disease for step 1 and step 2. Definitely need to know it. All right, case 3. We have a 65-year-old woman. She presents to the clinic with fatigue and occasional lightheadedness over several months. She also reports mild exertional dyspnea and brittle nails. Her nails are shown in the photograph. She is postmenopausal. She has no recent surgeries or obvious bleeding. She takes a multivitamin daily, but no other supplements. On exam, she appears pale with mild tachycardia. No lymphadenopathy or hepatosplenomegaly. Her rectal exam is positive for occult blood. Her labs show a hemoglobin of 9, MCV of 72, reticulocyte count is low, her serum ferritin is 10, serum iron is low, the TIBC is high, the transferrin saturation is low. So my questions for you is, how do we differentiate IDA, iron deficiency anemia, from anemia of chronic disease based on labs? What is your differential diagnosis for microcytic anemia? What is the best next step in the workup for a postmenopausal woman with confirmed IDA? A patient on oral iron supplementation presents with dark stools but has normal hemoglobin. Should we be concerned? Why or why not? And then a patient with a history of chronic transfusions is diagnosed with heart failure with preserved ejection fraction. How could iron be related to this new diagnosis? So pause, take a second, think about everything, and then we'll discuss. So this is your classic iron deficiency anemia, right? We have an older woman. They have fatigue, occasional lightheadedness, mild exertional dyspnea because we have anemia. We have low hemoglobin, so low oxygen transport to the tissues, which can give us a sense of breathlessness or dyspnea. She has tachycardia, right? Because my cardiac output is heart rate times stroke volume. If there's less oxygen getting to the blood, right, or getting to my end organs, the heart has to compensate by increasing the heart rate. So these patients often will have tachycardia. We see brittle nails, and we see this koilonychia, or I'm probably not saying that right, but the spoon-shaped nails, right, that are like they're almost pathognomonic for iron deficiency anemia. You won't see this unless the iron deficiency anemia is pretty severe. We also see she has no bleeding except from the rectum, right, which can be a little concerning. Um, and then we see a microcytic anemia. We see a low reticulocyte count, which checks out with iron deficiency anemia, because when iron deficiency anemia is severe enough, the lack of iron also inhibits the DNA synthesis, kind of like we talked about for our B12 deficiency, right? And so that can lead to an overall lack of reticulocytosis, so the bone marrow is not able to respond. We see a very low level of ferritin, very low level of iron, high TIBC, and low transferrin saturation. Um, so let's talk about it. So for iron deficiency anemia versus anemia of chronic disease, remember in anemia of chronic disease, ferritin itself is an acute phase reactant. So when the patient has a chronic disease or they have an acute inflammatory disease of any kind, right? So they're in sepsis or they have poorly managed lupus or rheumatoid arthritis. Ferritin is an acute phase reactant that's going to be released from the liver, and their ferritin is going to be high. So remember, ferritin is like the storage form of iron. Transferrin is more of the soluble movement form of iron. So in anemia of chronic disease, the ferritin's sky high because the iron's locked away in the liver, because during this inflammatory state, ferritin gets overregulated and hepcidin gets overregulated. Hepcidin is the guy that locks the iron into the liver, and it decreases duodenal absorption. So everything is locking the iron into the liver, so it's stored as ferritin. In iron deficiency anemia, the patient is losing the iron from elsewhere. So there's less iron total in their body, so there's less storage form of iron, so the ferritin is very low. The serum iron is going to be low in both. And then this is where the other difference comes in, is the TIBC, so the transferrin binding capacity. So I think about the transferrin binding capacity as the bus that takes iron around the body. So in anemia of chronic disease, the transferrin binding capacity is really low because all of the iron is locked into the liver. So there's no buses. There's no buses available. In iron deficiency anemia, the transferrin binding capacity is really high because there's less iron around, and any iron that's free is going to try to sit on the bus, right? So the bus has open seats and it's just waiting for iron to fill in, okay? But because there's less iron overall in the system, there's less seats that end up getting full, and so the TIBC ends up being really high. So eventually what's going to happen is these buses will end up getting over full with the iron that we do have available, so we can try to get any last iron to the end organs. So again, the TIBC is really important because in anemia of chronic disease, there's less transferrin binding capacity available. That's because all the iron is locked away. In iron deficiency anemia, the transferrin binding capacity is really high. That's because the bus has seats ready and available for iron to bind. And eventually the iron will bind any iron that we have in the body, because your body's desperately trying to get the iron onto these buses to take them to the end organs, right? So the way you can think about it is ferritin and TIBC are usually opposite, right? So in iron deficiency anemia, ferritin is really low and TIBC is high. In anemia of chronic disease, ferritin is usually high and TIBC is low. And then we have transferrin saturation, which is usually low, right? Because transferrin is not going to be totally saturated, because in both cases, iron is really low, right? So transferrin, again, is more of my soluble way that we can move iron throughout the system. In iron deficiency anemia, we have low levels of iron, so there's less transferrin saturation. In anemia of chronic disease, the iron's locked away, so we have less transferrin saturation. Um, Play around with the iron deficiency anemia and anemia of chronic disease labs. It takes a lot of time to just get them down like muscle memory. Eventually, you'll get them and you'll be able to explain them. All right. My differential for microcytic anemia is going to be my tails mnemonic. So thalassemia, we'll see an increased red blood cell count and usually normal iron. Iron deficiency anemia, which would be the most common cause. We have anemia of chronic disease. So that should be like your A in your tails mnemonic. I have it shown here as like the TIX L, which is another one. I usually do tails. But chronic disease, we just talked about it. Usually late Anemia of chronic disease can lead to microcytic. Otherwise, if it's early anemia of inflammation or chronic disease, it might be more normocytic. We have sideroblastic anemia, which can be classically caused by B6 deficiency. Lead poisoning can lead to it. So patients on isoniazid that causes a lack of B6 can lead to this. Um, and then lead poisoning itself. We might see GI, we might see neuro manifestations, we might see basophilic stippling. So the next step in a postmenopausal woman with iron deficiency anemia, we need to do a colonoscopy and an upper endoscopy. So this is really important. In a premenopausal woman who has iron deficiency anemia, we're not necessarily going to go right to the colonoscopy, upper endoscopy. That's because the patient may just be losing blood via menstrual cycle. They may be losing more iron than they should be, and we have a reasonable explanation. In any postmenopausal woman or any older man who's eating a normal diet and they have new iron deficiency anemia, that should be a massive red flag that the patient is probably losing occult blood from the stool. And it's a major sign that they may have a lower GI or upper GI bleed. We're especially concerned for a really like malignant lower GI bleed in the form of colon cancer. So we usually start with a colonoscopy, and then if we don't find anything, we might do an upper endoscopy to look at the esophagus and the small intestine. Um, Super duper duper important concept. So please understand that. Um, what if you see a patient who's taking iron pills and they have dark stool, but they have normal hemoglobin? Do we worry? No, not at this point, because iron ends up turning the stools dark or black. It can almost look like melena. So as long as the patient doesn't have GI symptoms, as long as their hemoglobin is normal, they have normal vitals and they're stable on all their labs, I would assume that this dark stool is secondary to the iron and not secondary to a GI bleed. Okay, take it into clinical context, but a very commonly asked question, something very common you'll see on the wards, is a patient taking iron who has dark stools. So you can't be fooled by that. Um, and then a patient with chronic transfusions who has new HFpEF. Well, this patient getting chronic transfusions is probably an iron overload. Iron overload can deposit into the myocardium and can cause a restrictive cardiomyopathy. So that can then lead to diastolic dysfunction. So the heart is not able to expand and accept volume like it normally does. So it leads to a restrictive cardiomyopathy. Systolic wise, it's still able to pump totally fine. It's just not able to accept as much blood because the iron is compressing the myocardium. And so in this case, it's called diastolic dysfunction or HFpEF, heart failure with preserved ejection fraction. Something to consider on all your patients getting iron transfusions. All right, case number 4. We have a 10-year-old boy with known sickle cell disease. He presents to the emergency department with severe bilateral hand and foot pain that started this morning. His mother says that he has had similar episodes before, often triggered by cold weather or dehydration. He has had multiple hospitalizations in the past for pain crises and once for acute chest syndrome at age 7. He is currently on hydroxyurea. His vital signs, his temp is 99.4, heart rate 110, respiratory rate 20, blood pressure 104/62, oxygen sat 98. His physical exam, he's irritable. He's got swollen tender hands and feet, no focal neurological deficits. He's got a hemoglobin of 8.5, a little below his baseline, white blood cell count 13, platelets 450, reticulocytes are elevated. So for this guy, what is the underlying genetic defect in this patient's condition? Should this patient be on antibiotic prophylaxis? If so, which and why? What is the purpose of hydroxyurea in patients with sickle cell disease? If this patient presented with sudden hemiparesis and was diagnosed with a stroke, how would we manage it acutely? Why is 0.45% saline often used during acute pain crises or dactylitis episodes? How do we treat acute chest syndrome? And after age 5, sickle cell patients are functionally asplenic. Which infections are they most at risk for, and how should we prevent them? So pause your screen and think about it. So for sickle cell disease, the underlying genetic defect, we have that point mutation in the beta globin gene on chromosome 11. So that turns glutamic acid into valine at position 6, which can lead to the hemoglobin S formation, right? So glutamic acid is charged, valine is not charged, so that throws off the relationship between my amino acids in their tertiary and quaternary structures, right? So that can end up leading to the hemoglobin S formation. The hemoglobin S polymerizes under low oxygen and leads to sickling. So for antibiotic prophylaxis, yes, the patient should be on penicillin until age 5, right? So that's like classically like asked question. And then we can consider penicillin after age 5, but it's more of like a shared decision making, right? It's kind of based on the individual themselves. Um, this decreases the risk of invasive strep pneumo infections, and we also want to vaccinate against strep pneumo. The use of hydroxyurea. So hydroxyurea inhibits ribonucleotide reductase. Via an really unknown mechanism, the hydroxyurea increases hemoglobin F, so the fetal hemoglobin, and fetal hemoglobin is more resistant to sickling. So it increases fetal hemoglobin, which will have less sickling. So we're able to reduce those pain crises. We're able to get more oxygen to our tissues, right? Um, this is indicated, hydroxyurea is indicated for when you have greater than 3 pain crises a year, acute chest syndrome, or severe anemia. Remember, hydroxyurea it's not like an amazing drug that like kind of treats sickle cell disease. It has side effects. So hydroxyurea, by blocking ribonucleotide reductase, can lead to immunosuppression. It can lead to all of those causes of megaloblastic anemia that we talked about, right? So it can decrease DNA synthesis, so it can lead to that. So it's all things we need to consider when putting a patient on hydroxyurea. So stroke management, this is like a classic step 2 question. If you have a patient with sickle cell disease and stroke, the management's a little bit different than what we would do for just kind of a regular patient with stroke. So in this case, we want to emergently do exchange transfusion. Okay, we want to rapidly lower the percent of hemoglobin S in their system. We're aiming for hemoglobin S less than 30%, right? Because what's causing their stroke is the sickled cells getting stuck in my circle of Willis, cutting off blood supply. So if we do emergent exchange transfusion, remove the sickled cells, add in back normal cells, we restore perfusion. Okay, so that's the treatment there. Um, Sometimes, for question 5, sometimes 0.45 normal saline is used in acute pain crises. So patients in acute pain crises are often hypovolemic, so they need some sort of fluids. Sometimes we'll go for 0.45 normal saline because that's a hypotonic solution. So when I give them normal saline, there's less solute in the intravascular space. And so what's going to happen is the fluid is going to flow into the red blood cells to equalize the amount of solute inside the red blood cells and inside my intravascular space. And so by having the fluids flow into the red blood cells, it can actually expand the red blood cells. So sometimes that's why it's used occasionally in acute pain crises. Probably not going to show up on any standardized exam, but can come helpful on the wards when you're dealing with a patient with sickle cell disease. So acute chest syndrome, right? It's really hard to tell acute chest syndrome from a bacterial or viral pneumonia. So we just assume, even if the patient has sickle cell disease and we're like, yeah, this is probably acute chest syndrome, we assume that they have an underlying infection, because if we miss the underlying infection, it could be extremely deadly in a patient with sickle cell disease. So we start them on our normal community-acquired pneumonia antibiotics, something like ceftriaxone, a beta-lactam, plus azithromycin, a macrolide. We'll give them O2. We can use incentive spirometry. We'll do pain control, IV fluids, and we can use exchange transfusion if it's severe. And then infection risk, like after age 5. So classically, after age 5, these patients will be functionally asplenic, meaning the sickled cells have blocked off the splenic artery. The spleen's no longer getting blood supply. It's not working. It's functionally dead, but it's still within the patient's body. So here, we're really worried about encapsulated bacteria because the spleen is really important for making uh, plasma cells that will then create antibodies that attack the encapsulated bacteria. And the spleen itself makes macrophages that are really good at phagocytosing some of these encapsulated bacteria. So if we lose the spleen, we lose our ability to fight off some of these encapsulated bacteria. The big ones we need to worry about are my shins, right? So strep pneumo, Haemophilus influenza, Neisseria species, and Salmonella. Those are the ones we want to worry about. So we're really going to focus on vaccines. And when a patient with sickle cell shows up with some sort of kind of a picture of infection, we have to think about my encapsulated bacteria. All right, almost done. Two left. So we have a 28-year-old man of Mediterranean descent presents to the emergency department with dark urine, fatigue, and jaundice that began 2 days ago. He reports that he recently recovered from a sinus infection for which he was prescribed TMP SMX. He denies any family history of blood disorders. On exam, he is pale and mildly icteric with no hepatosplenomegaly or lymphadenopathy. His labs, we see a hemoglobin of 7.8. His baseline was 13. The reticulocyte count is way up. Total bilirubin, his indirect is up. LDH is up. Haptoglobin is undetectable. Coombs test is negative. His peripheral smear is shown. So, what are some common precipitants of hemolysis in patients with G6PD deficiency? What is the underlying pathophys of G6P deficiency that leads to hemolysis? What are the roles of NADPH in red blood cells? Why is it so critical? Why might G6PD levels appear normal during an acute hemolytic episode? And why must we be cautious when giving methylene blue or resburicase to patients with G6PD deficiency? So pause your screen, think about all this, and then we'll discuss. So some common precipitants of hemolysis are going to be drugs like sulfa drugs, TMP SMX, dapsone, nitrofurantoin, antimalarials such as primaquine and aspirin in high doses, certain foods, the classic one is fava beans, and then certain stressors, infections, ketoacidosis, surgery, all things you need to be aware of. The pathophys, G6PD, it generates NADPH via pentose phosphate pathway. NADPH maintains glutathione in the reduced form, which detoxifies reactive oxygen species. So if we don't have G6PD, we don't make the NADPH, we don't reduce the glutathione, and we don't detoxify these reactive oxygen species, and that leads to oxidative damage. That can then lead to the formation of Heinz bodies in the red blood cells, red blood cell membrane damage, and then extravascular and intravascular hemolysis. So again, the NADPH in the red blood cells, it protects the red blood cells from oxidative stress. It keeps the glutathione reduced, and it prevents hemoglobin denaturation. NADPH is also really important in fatty acid synthesis, right? It's an anabolic compound. So why might G6PD levels be normal during a crisis? They're older red blood cells that are the most deficient in the G6PD. Those older red blood cells are usually lysed first. So as the red blood cell ages, the G6PD levels decreases. And it's those older red blood cells that get lysed first. So the newer red blood cells actually stick around a little bit longer in these acute crises. And those newer red blood cells have almost or normal G6PD levels, right? So it kind of leads to like a false negative test, right? If I test my patient for G6PD levels in an acute crisis, we're really just testing their newer red blood cells that classically will have normal or very close to normal G6PD levels, and that will lead to a false negative test. So we really want to retest the patient 2 to 3 months after their acute crises, right? So we can get a true test. And then why do we want to avoid methylene blue and resburicase? Both can generate oxidative stress. So methylene blue requires NADPH to work, and it's ineffective and worsens the hemolysis in G6P deficiency. Resburicase itself forms hydrogen peroxide, which triggers oxidative damage in the G6P deficient cells because those G6P deficient cells can't make NADPH, they can't reduce the glutathione, they can't protect themselves. So methylene blue is used oftentimes in methemoglobinemia, where the iron is Fe2+, it gets transformed into Fe3+. Fe3+ can't really bind oxygen as well. So that's a huge problem, right? So we can give the patient methylene blue that can convert the Fe3+ back to Fe2+. If the patient has underlying G6P deficiency, we can't give them methylene blue. We can give them IV ascorbic acid, which is IV vitamin C. So that's the second line. Respiricase can be used in like acute gouty crises. It can also be used in tumor lysis syndrome, but we have to be careful, right? If the patient has G6P deficiency, we probably don't want to use that one. All right, last case. So we have a 7-year-old boy is brought to the emergency department by his parents after he developed significant swelling and pain in his right knee following a minor fall on the playground. His parents mentioned that this has happened before with relatively minor trauma. He also has a history of easy bruising and prolonged bleeding after tooth extractions. His maternal uncle reportedly had a similar bleeding disorder. His vitals are normal. His exam shows a large right knee effusion with limited range of motion, no signs of infection or systemic illness. His platelet count normal, PT normal, his PTT is prolonged, factor 8 level is low, factor 9 level normal, von Willebrand factor antigen normal. So what is the inheritance pattern of hemophilia A? How might desmopressin help this patient? What are other clinical situations in which desmopressin can be used? Why might factor 8 levels be low in von Willebrand factor disease? And what is a likely explanation if a patient receiving long-term recombinant factor 8 therapy suddenly stops responding? So pause your screen and think about all this, and then we'll discuss. So again, this is hemophilia A. It's an X-linked recessive pattern of disease. So it affects male, and it's often inherited from the carrier mothers. Because remember, your mothers are going to be XX and will pass on the X to the male. The dad will pass on the Y to make your male, right? XY. Female carriers are usually asymptomatic. Occasionally, you can have lionization where one of the X chromosomes gets inactivated, and that's when a female may present with signs and symptoms of hemophilia A. Very low yield, very rare, so not going to show up on step 1 or step 2. There's a 50% of chance of passing to your sons. How does desmopressin help? So remember, desmopressin is recombinant antidiuretic hormone. This actually stimulates the release of von Willebrand factor and factor 8 from my endothelium. So it's useful in mild hemophilia A because it increases the factor 8 levels temporarily, and it increases the von Willebrand factor temporarily, and von Willebrand factor actually kind of forms like a protective casing around factor 8. Both of those can increase the factor 8 levels for a short period of time. Other uses for desmopressin, type 1 von Willebrand disease. So type 1 von Willebrand disease is when we have a low level of von Willebrand factor. So I just told you desmopressin can increase von Willebrand factor numbers, right? So that can help. Central diabetes insipidus. So in central diabetes insipidus, the patient isn't making antidiuretic hormone. So antidiuretic hormone can't go down to the distal convoluted tubule and the collecting ducts and activate the V2 receptors, which causes the aquaporins to move over and allows for water reabsorption. So in these patients, if they're not able to maintain the amount of water they're drinking, they're going to have really dilute urine because we can't reabsorb it, and they're going to have really concentrated serum, so they're going to have really high hypernatremia. Now, this is a story for another day, but as long as the patient's able to drink enough water to thirst, they're able to keep those electrolytes within normal limits. It's when they don't have access to water, that's when things can get out of hand. But obviously, if we give them desmopressin, we're giving them the hormone they're missing, and that can help correct the problem. And then there's nocturnal enuresis. So that's peeing during the night, especially in little kids. By giving them desmopressin, right, it helps water reabsorption, which will decrease urine production at night. So why is factor 8 level low in von Willebrand factor disease? I kind of already alluded to this, but von Willebrand factor stabilizes factor 8 in the plasma. So without von Willebrand factor, factor 8 is degraded pretty rapidly, which leads to low factor 8 levels. So that's why in von Willebrand factor disease, we can see an elevated PTT because factor 8 is part of my intrinsic pathway. So if the von Willebrand factor deficiency is pretty significant, then we're going to lose enough of my factor 8 to actually cause an elevation in my PTT. So this is especially seen in type 3 von Willebrand disease where the patient has severe von Willebrand factor deficiency. And then my last question was, the patient had a loss of response to factor 8 therapy. Why? This can happen when a patient is on long-term recombinant factor 8 therapy, or factor 9 for this case for hemophilia B. It's because the patients will develop inhibitory antibodies against the recombinant factor 8. So I'm giving the patient this recombinant factor 8 that looks awfully close to the factor VIII we can make in our bodies, but it's not perfect, right? So over time, your immune system is able to mount a response against this abnormal protein and make antibodies against it. So you'll see a patient that responds really well, and then all of a sudden they stop responding, and their PTT goes up and up and up and up, and they start bleeding again. That's when you should consider they have mounted an immune response. So what we do is we confirm with this thing called a Bethesda assay that can tell us the level to which the patient has antibodies in their system, and then we can kind of go from there. So we covered a lot. So we covered macrocytic anemia, microcytic anemia. We talked a little bit about normocytic anemia too. We talked about sickle cell G6PD deficiency. We talked about hemophilia A and hereditary spherocytosis. We also brought in von Willebrand factor disease. So all very high yield topics. Hopefully this helped. Reach out if you have questions. There's my email. Until next time.